May the light of your soul guide you. May the light of your soul bless the ministry you do, with secret love and warmth of your heart. May you see in what you do the beauty of your own soul. May the sacredness of your ministry bring healing, light, and renewal to those who minister with you and to those who see and receive your ministry. May your ministry never weary you. May it release within you well springs of refreshment, inspiration, and excitement. May you never be lost in bland absence. May the day never burden you. May dawn find you awake and alert, approaching your new day with dreams, possibilities, and promises. May evening find you gracious and fulfilled. May you go into the night blessed, sheltered, and protected. May your soul calm, console, and renew you. Today is a feast of Our Lady of Fatima, so we ask Our Lady of Fatima to pray for us. And our moderator today is Dr. Korche, and our presenters are both Dr. Yacoubians, and we're privileged to have their father, another Dr. Yacoubian, present with us today. Welcome.
I'd like to welcome you all to the kickoff of our Musculoskeletal Month of lectures here for CME. We'd like to introduce today, I'm sure most of you know, esteemed members of our staff, Dr. Stephan and Stephan Yacoubian. Stephan's been here actually. I've had the pleasure of initially meeting him 8 years ago. He's been on staff here for 8 years, and his brother joined our staff about 4 years ago. And I can tell you it's been a pleasure to work with both of them. Both of them are trained at the Albert Einstein College of Medicine in residency in orthopedics. Stephan went on to do his fellowship training in sports medicine and arthroscopy at the University of Connecticut, and Stephan went on to Brigham Women's Hospital at Harvard to do a joint fellowship. So without further ado, I'd like to introduce Stephan, who will begin the first part of today's talk.
I'm going to be presenting a talk on rotator cuff injuries today for the sports medicine portion of our series. And I just chose the rotator cuff injuries because it's very common in the community, and I think it's relevant for most people who treat musculoskeletal problems. I wanted to start with a case presentation of a typical patient seen in the office in this community. And here we have a 56-year-old woman who presents with left shoulder pain of 4 months duration. No specific trauma, but she's very active, plays tennis 3 times a week, and she has pain with overhead activities. She's had mild relief with Motrin, but the pain's been persistent. She's essentially healthy, no past medical problems, otherwise a healthy woman. And on examination, I just wanted to go through some of the orthopedic lingo in exams. That way we can get a little comfortable on some of the words used when orthopedic surgeons are discussing examination findings. Positive Hawkins sign. She had a positive Hawkins sign. That's essentially elicited by moving the arm in forward flexion position and then internally rotating, and that would cause pain and reproduce the patient's discomfort at the shoulder. Also, this patient had mild limitation in the range of motion. Her supraspinatus strength was 3 out of 5. The supraspinatus is the strongest of the rotator cuff tendons, and lastly, she had a positive drop arm test, and that's illustrated below, where the arm is brought into abduction, and the patient cannot keep it abducted under a force, under a downward force. So basically, the arm drops down. Thus, the name of the exam. So our patient had these type of findings, and on X-ray, you can see what the problem is right here. This is called the supraspinatus outlet view, and you can see that the acromion, which is this structure right here, comes to a very sharp edge, and that's commonly referred to as a bone spur or an acromial hook. And essentially what's happening is that bone spur is digging into the underlying structure, which is the bursa and the rotator cuff, and that's what's causing the pain when she brings it up. Neer classified the variations in human acromial anatomy into 3 types, and very simply they are type 1, where it's a very flat acromial surface, type 2, where there's a slight hook, and the type 3, where there's an accentuated hook. And obviously this patient is a type 3 acromion, and thus her findings. Next, so far, based on the history of this patient, the examination, the x-ray findings, you're pretty comfortable making the diagnosis of subacromial impingement syndrome, and she also possibly has rotator cuff injury. We cannot prove that without an MRI, but we can have a pretty decent sense on physical exam that there's injury to the rotator cuff. Initially, just given that, what I'd like to do is start a conservative management course with simple non-steroidal anti-inflammatory medications, steroid injection, and finally physical therapy. Physical therapy is done for about 4 to 6 weeks for the rotator cuff strengthening exercises, range of motion, and I feel that these 3 modalities generally produce good outcome in a lot of patients. Now, granted, this patient has a type 3 acromion, and her chances of having a successful conservative course are smaller than somebody who has a type 2 acromion or a type 1 acromion. But just for the sake of this discussion, it's important to stress that conservative management is always tried first before anything else is considered, including, in my case, in my practice, an MRI. So just to take a moment to discuss impingement, it's the most common cause of shoulder pain that I see in the office, and can often lead to bursitis, and that can also lead to a rotator cuff tear. Now, this is a continuum of one entity to another, and it can create sort of a vicious cycle. And I just wanted to spend a minute discussing this, because I think if you have an appreciation for this slide, it goes a long way in understanding what's going on in the subacromial space and rotator cuff problems. So essentially, the shoulder anatomy, put simply, here's the clavicle. At its distal end is the acromioclavicular joint, and it meets the acromion, which is part of the scapula. Underneath that is where all of the pathology is occurring. Generally, the bone spurs can be located here at this location, and also at the distal end of the clavicle. And this big ballooned red structure here is the subacromial bursa, and in this illustration it is irritated and painful. And underlying the bursa is the supraspinatus, or the rotator cuff, and in turn that can become irritated over time. So when you have impingement with a bone spur, that can lead into bursitis, it can lead into rotator cuff tendinitis, it eventually can lead into a rotator cuff tear. And these big arrows going down represent the usual progression, or a possible progression, but also the vicious cycle is also illustrated with the smaller arrows pointing in the opposite direction, where a rotator cuff tear and tendinitis can also lead into bursitis and further impingement. And I'm going to illustrate that a little later on the MRI. So essentially, that's the pathological the process that occurs. Now, what's the normal anatomy and function of the rotator cuff? The rotator cuff is a combination of 4 muscles that allow shoulder to perform powerful motion. It also allows the shoulder to perform very common motion too, like combing your hair or reaching high shelf. And to illustrate, we have an anterior view here, or a front view of the anatomy of the shoulder. And this large muscle here is the subscapularis, which is one of the 4 muscles of the rotator cuff. The supraspinatus, which sits up top, that is the strongest of the rotator cuffs and the one most commonly torn. Inferior from that posteriorly is the infraspinatus, and the smallest contribution comes from the teres minor in the posterior inferior aspect. Anatomy of the tear. So where does the tear generally happen? This is just a lateral type projection of the shoulder. Here you have the humeral head and the shaft below, and the acromion up top. It's a slightly different projection from the one I showed you earlier. And here, this red structure is the rotator cuff muscle belly, and as it comes laterally, it's turning into the tendon, and the tendon is inserting into the bone right over here. And same with the infraspinatus and the teres minor and the subscapularis up front. Generally, the tear occurs right over here at the supraspinatus, infraspinatus area, which is in the superior aspect. That's a very, very typical place where we find a tear. Now, what's the role of MRI? In my practice, when I first meet the patient, like the typical patient I discussed above, I don't order an MRI right away because I find that with the conservative management, a lot of people don't ever need to go that route and we don't need to have an MRI. But for the patients who do return and they have persistent pain and they fail the conservative course, I order the MRI. Here's typical findings of MRI. The first illustration is generally a normal MRI. This is a coronal T1 image. And this black structure here, this is the supraspinatus muscle belly, and if you follow it laterally into this yellow circle, you can see that black tendinous line, and that's the supraspinatus tendon, and it's inserting normally into the humeral head, and that's a normal rotator cuff and insertion right over here. Also, you can see that the humeral head, which is this round ball here, and the shaft, is in a very normal anatomic relationship with the glenoid, or the socket. You can see that the ball and the socket are at the same level inferiorly. If you compare that over here, you can see that the ball all of a sudden is now higher within the socket, and it's covering, it's 1/3 higher than it was over here. So in this scenario, what's happening is that the humeral head it's a high-riding humeral head. And that's the vicious cycle I was describing earlier. Now that the humeral head is rising up and increasing the impingement up top and causing further tear in the rotator cuff. Here you can see the supraspinatus muscle belly, and following it out laterally, you can see that it's become a thin black structure right over here, and you can see fluid at both on the superior aspect and inferior aspect of the tendon, and that's generally a partial tear. But you see continuity of the tendon all the way across, so there is no full tear, it is a partial tear. Lastly, it's a little dark, but it was made that way so you could see that there is generally no tendon signal above the head. It's completely white up here, and that's a complete rotator cuff tear. And also notice that the head has ridden even higher in the shoulder, and now this causes further impingement, further bursitis and inflammation and pain, and also weakness because the rotator cuff is torn. So that's a full tear, and schematically it is illustrated here. Anatomically, this location correlates to this right here on this image. So we discussed the symptoms of the impingement syndrome. For a rotator cuff tear, it's essentially the same, but with some changes, with more weakness, more pain, and more recalcitrant course with physical therapy. Generally, it's pain in the lateral shoulder. The pain can even be a little lower down than the actual anatomical location of the tear. And it generally doesn't travel below the elbow. There's weakness with overhead motion, and there's rarely ever any swelling or point tenderness for rotator cuff tears. And sometimes it can be difficult, especially given the size of some patients, it can be difficult to localize the area of the pain. So for treatment, as we discussed for the impingement syndrome, for rotator cuff problems, strain and partial tears are treated very conservatively with activity modification, medication, physical therapy. And for tears that are resistant to physical therapy, then we discuss surgical intervention with the patient. So arthroscopic shoulder surgery in the scenarios that I presented here can be done for either impingement alone or for impingement with the presence of a rotator cuff tear. And generally that surgery is done under general anesthesia, sometimes with an interscaling block, which can help with postoperative pain. So puts very simply, what are the goals of subacromial decompression? They are to flatten the acromial hook or spur that I illustrated, to debride the irritated bursa, and also to assess the other structures around the shoulder, such as the cuff itself, the labrum, the articular surface, the cartilage surface of the joint, the acromioclavicular joint, and bicep tendon. These other structures also can be very easily observed with arthroscopic surgery. And that's one of the beauties of arthroscopic surgery, is that it allows you to assess the neighboring structures very easily and without disturbing those structures, compared to the way things used to be done with open surgery, where there was a lot of trauma, a lot of bleeding, and you could barely assess the structure you're going in for, let alone the normal neighboring structures. So for the goals of the surgery for rotator cuff is to repair the rotator cuff, and that's generally done with suture anchors. So for arthroscopic surgery, generally we do it with arthroscopic portals. And the illustration up in the top left corner here shows some of the possible areas where portals can be placed. They're numbered 1 through 6. Generally, 99% of the time for rotator cuff surgery, only 3 of these portals are utilized and necessary, which is the posterior portal number 1, the lateral portal number 3, and the anterior portal number 4. Surgical markers are always used to outline the anatomy to make portal placement easier. Here you can see that the illustrations are showing the acromion, the AC joint, and the clavicle, and it just makes portal placement much easier. And everything is visualized on a video screen, and minimally invasive incisions are made, and that's how we proceed with the arthroscopic shoulder surgery. So in the case of just subacromial impingement syndrome without a rotator cuff tear, that the patient's failed physical therapy and conservative management, we do what's called a subacromial decompression. And going back to the patient illustration that I showed you earlier, you see that type 3 acromion with the hook. And generally, typically we use, this is a operative image here. And we're looking right inside the subacromial space, so we're looking in this space right here. You can see this is the acromion, and you can see it's coming down into the sharp tip right over here, so that tip correlates to here. And this is a 4.0 millimeter barrel-shaped burr, and this spins at about 9,000 rotations per minute. That's pretty fast, and it pulverizes this bone spur and flattens out the undersurface of the acromion, thereby hopefully eliminating the impingement and the pain. So that's the subacromial decompression. In the instances where the rotator cuff is also torn, we do the subacromial decompression, and that's followed by repair of the rotator cuff. And visually, this is what it looks like. This C-shaped structure here, this white structure, is the torn edge of the rotator cuff. That correlates to the supraspinatus tendon. And this fuzzy material here, that's where it tore from. So it used to be this white structure used to be attached to the humeral head right over here, and it tore over time. And this line of demarcation here, that's where the articular cartilage begins, and the humeral head then follows in this direction over here. So basically, we have some sutures here around the rotator cuff, and this red arrow here is pointing to a suture anchor that's been placed in the bone, and the sutures are then passed through the rotator cuff and tied down, thereby stabilizing the rotator cuff and repairing it. And this is an image of a 2-anchor repair. You can see there's 1 anchor here and 1 anchor over here. Typically, this is what a suture anchor might look like. This is an example of a metallic anchor. Some surgeons prefer using metallic anchors. Other surgeons prefer using bioabsorbable anchors. The difference is that the bioabsorbable anchors over time can resorb and turn into bone, and the metallic anchors don't. But again, it's a pure surgeon preference. So you have the anchor material here, and the pitch of the threads of the screw are ideal for cancellous bone fixation. So you get a very, very strong fixation. Once you put this anchor in, it's nearly impossible to pull it back the other way. So these sutures are then attached. You have 2 sutures here, a white one and a blue one in this case. And again here we have the torn edge of the rotator cuff shown here with the white structure. And the suture anchor, this metal anchor, has already been placed in the bone, and the suture is already run through the rotator cuff. And on this image, it has been tied down and repaired. Over here, I thought it'd be interesting to show a post-operative MRI, because you can see the suture anchor right over here on the MRI image. This is not a metallic anchor. This is an absorbable anchor. You can see the threads very nicely right over here. And you can also see that the rotator cuff tendon, which is this structure here, has been very nicely seated onto its anatomical location, and this is amenable to healing. Postoperative protocol for if they just had the subacromial decompression without a rotator cuff repair, then it's fairly straightforward and a quicker recovery course than with rotator cuff repair. Quite simply, the patient wears a sling for several days. They start some range of motion and strengthening on their own, and then they go to physical therapy a week later. Sutures are removed at 1 week. They can return to work, typically, depending on the type of work, 1 to 2 weeks, and they can return to sport. Hopefully, that 4 weeks may be a little fast for returning to sport for a subacromial, maybe 6 to 8 weeks. Post-op therapy for a patient who had, say, a rotator cuff repair as well as a subacromial decompression. The goals of the therapy are quite clear. Is to maintain the range of motion of the shoulder without jeopardizing the repair. So those anchors that were placed in the bone and pull the rotator cuff down, that's just the start of the healing process. It takes biology many weeks in order for that tendon to then insert into the bone and heal there. So during the course of that time, it's essential that we don't lose range of motion in the shoulder and maintain the shoulder range of motion until that healing occurs. So that's why physical therapy is very key for rotator cuff repairs. The physical therapists are very essential in maintaining that range of motion and keeping the patients from doing too much too soon, activities which can jeopardize the repair. The strengthening, actual resistance strengthening can begin 6 to 8 weeks depending on the patient, depending on how they're doing. So postoperative therapy for cuff repair, again, outcome of surgery heavily dependent on physical therapy. The shoulder is generally braced 4 to 6 weeks. They can start just gentle pendulum exercises, just pendulum with gravity in the first week. And passive range of motion is done with the physical therapist to maintain that motion, and strengthening 6 to 8 weeks. Back to sport activities with rotator cuff repairs are going to be longer than with just subacromial decompressions, and that's going to vary 3 to 6 months or even longer depending on the sport. Here we have a typical patient who's very aggressively doing their physical therapy. In this illustration, he's about 3 months out from surgery. He's very excited and he was very enthusiastic. And here he is at about 6 months. Yeah, as you can see, he's exceeded all of our expectations. This guy did really well. So, in summary, shoulder impingement, bursitis, tendinitis, rotator cuff tear are a continuum of the same pathological process. These entities are often present simultaneously. Conservative management works in many cases, and shoulder arthroscopic surgery is a reliable and minimally invasive procedure to address these problems, and physical therapy is essential in its outcome. Thank you very much. Thank you.